Hello and welcome to Common Sense Oncology's video podcast. I'm Brooke Wilson, medical oncologist and clinician scientist at Queen's University and Kingston Health Sciences Centre in the snowy Kingston, Canada. Thank you for joining us today. As a reminder to our listeners, Common Sense Oncology is a global network of oncologists, patient advocates, researchers, and partners focused on advancing patient-centered care in cancer and research. Today, I'm delighted to welcome a special guest to our podcast series, Dr. Richard Sullivan. He's going to speak to us today about the recently released Lancet Oncology Commission on the Human Crisis in Cancer Care, which he co-led with several partners from around the world, including several here in Canada. Welcome, Richard.
Lovely to be with you, Brooke. Thank you for asking me.
So Dr. Sullivan is a professor of cancer and global health at King's College in London, where he also serves as the director of the Institute of Cancer Policy and co-director of the Center for Conflict and Health Research. His research focuses on global oncology, including health services, systems, and policy, as well as the challenges of cancer care in conflict zones. He serves as an advisor to several international organizations, including the WHO, and has led several commissions in the Lancet Oncology. Today, he's graciously agreed to speak to us about his most recent commission, The Human Crisis in Cancer Care, which was published in the November issue of Lancet Oncology. So thank you again for joining.
Wonderful. Thank you.
So Richard, to start off, can you tell us a little bit more about what is the human crisis in cancer care and how is it that this important commission came to be?
Well, it was an interesting gestation. Maybe I'll start with that because I think originally we had thought about the crisis in humanitarian settings because people will be very aware now that probably around 2.5 billion people live in conflict or fragile affected settings. And so originally we'd thought about this idea of humanitarian crises, but really the more we talked amongst ourselves and talked to our colleagues around the world, we realized that actually the crisis was much broader and much deeper. And really what we were looking at was a human crisis in cancer. This wasn't a crisis just affecting people in low and middle income countries, in fragile and conflict, but were really affecting patients across the economic groups. And really to sort of succinctly put this into perspective, we've kind of proposed that the human crisis has been really defined by pathology, mortality, or cause, but that isn't the issue. Really, we're talking about the erosion of meaning and connection and compassion within cancer care. It's the relationship aspects that define high quality cancer care. Now, the causes, of course, of these are multiple. This is about fragmentation of systems. This is about problems with an overfocus on the commercial, technical aspects of cancer care in comparison to the greater needs of the human being. It's about the erosion of core aspects and core disciplines like mental health, psychosocial, and palliative care. And really, I think from the commission where it gestated from was this idea that the human crisis was again a much bigger problem than simply the mortality, the risk burdens, etc.
It's a fascinating commission. And one thing I noticed is that throughout, an emphasis is placed on this deep misalignment between the current cancer system and what really matters to those living with cancer and their caregivers. But this misalignment spans all aspects of our system. It runs from the current research environment to the way the health system is designed to the economic incentives that drive our current system and processes. Tell us more about this. And, how did we get to this profound misalignment?
The misalignment, I think, has a kind of depth and complexity to it that has made it quite hard unpacking because those misalignments occur in different dimensions depending on where you are in the world. You have misalignments at the kind of the fundamental level of care, where individuals are treated for a disease, for molecular aberrations, rather than for the context of their specific lived lives, their social histories, their family histories. And we're increasingly seeing that in a lot of high-income countries, where individuals are often treated as a kind of the tumor, rather than as individual patients with lived lives. On the other extreme, we have individuals being cared for in systems which are completely overloaded, where outpatients may have two, 300. So it's the structural deficits make it almost impossible to give that holistic, patient-centered care. And so you got these extraordinary differences across different sorts of systems. And the misalignments, you say, go from this very micro level all the way up to the macro level, where we see misalignments in the way that money is given to research and development. And we talk an awful lot about this in the commission, about how the R&D systems that drive innovation within cancer are misaligned. They're misaligned in terms of where the money is going. So it's all focused on biopharmaceutical and discovery science at the expense of other areas. It's misaligned because so much of it is focused in high-income Western countries, and so little of it is being actually conducted in countries in middle-income and low-income countries that need it. And it's misaligned because it often pushes to the side aspects of research, social, economic, implementation science, psychosocial, mental health, palliative care, which are really important to patients and to understanding lived experiences at the fundamental level. And what we've done in the commission is try to dissect these really quite sophisticated, complex issues and misalignments apart to give some framework for later on, as we will probably discuss, the solutions, because I think it's very easy to articulate problem sets in crises, and we're very good at articulating problem sets in crises. But that's no good unless you can align it with policies, the politics, and the solutions, which are going to lead to change and real fundamental change in the future.
Thanks, Richard. And definitely, I want to delve into solutions in a little bit. But before we get to that, one of the things that I thought was interesting is that this commission really does take a truly global lens. And you just alluded to the fact that you looked at how this is presenting itself in different economic contexts. So given this, do you feel that there are unified solutions that can be taken, given that the issues may not be entirely the same depending on the context? Tell us a little bit about that.
Yes, and I think this is where the complexity and nuances come in, and there's a particular bugbear of mine, and we talk about low middle income country cancer control, or global south cancer control, or high income cancer control, which is not a nonsense. You're putting people from Chad and China into the same group. And even when we look at individual countries, the demographic leviathans like Nigeria and Brazil and India, we see within those countries the entire spectrum of the world there, from high income to low income. Likewise, you can go to many high income countries and find really seriously deprived areas in those countries where the social structure, the social determinants, the economic determinants reflect lower middle or even low income countries, even though they may be in a high income setting. So one of the things we really do in the commission is kind of create some specificity to say that a lot of what we're talking about are generalities, but what really matters for change are the specifics of those countries. But you asked about, are there generalities here? And I think at the first level, there are generalities in principles and values. I think that's something we really hammer home, is that the principles of sustainability, the principles of compassion, the principles of high quality care centered on a human being are the same around the world, irrespective of your setting. Yes, the level of treatment may be different because of the economic settings, all the types of cancers, etc. But there are sort of fundamental principles of basic human nature in terms of compassion, understanding, society, culture, which are the same around the world. And then there are, I think, some broader areas which do cut across, which is what matters to actually improving human-centered care. What do we actually need to do in the research ecosystem, for example? So the talk discussion, for example, and this is just a very specific example on the second translational gap in implementation science, in health service research. This is a truism for Botswana as it is for Brazil. The levels and what you might focus on are different, but the generalities are the same. But it's a complex matrix, and I think what in the commission we try to do is to leave people to make the decisions about how those generalities actually mattered for their specific settings.
Yeah, no, I think the commission does a really fantastic job of thinking about all those different aspects from different lenses and presenting, potential solutions that are applicable in different settings. So it's a really interesting piece of work. I wanted to pull out one of the quotes from the manuscript and hear a little bit more about your thoughts. You write, time pressures, administrative burdens, and emotional fatigue are common features in high throughput systems that can contribute to this dehumanization of cancer care. And from a clinician perspective, that resonated really strongly with me. And so I ask you, do we need new solutions, new ideas, new investment, or do we simply need to do a better job with the resources at our disposal to address some of these challenges in everyday practice?
Yeah, it's a great question. And I think it comes back fundamentally to this idea of what we mean by the human crisis in cancer, because we're not just focusing on families and people living with cancer. This is also about the enormous workforce that's involved in the care of patients, both in hospitals and in the community settings. And as I think you rightly identified there, this is the care workforce has not been a subject matter for many previous commissions, nor for, I would argue, the wider policy dialogue. We talk a great deal about workforce deficits. We talk a great deal about this aspect of having to build in specific disciplines, and they've been touched on in various commissions before this one. For example, the surgical commissions, the commissions, radiotherapy commissions, etc. But when you kind of boil down, it's more than just numbers here. It's about the experience of those healthcare workers within their respective systems, their feeling of value, the kind of relentlessness of clinical practice, which, as you said, leads to enormous burnout and or moral distress. The inner knowing you are unable to deliver good quality care because of the structural or financial system that surrounds you. And it's interesting how these moral distress and burnout manifest themselves in similar ways across very, very different settings. So you can see this in settings where there is a one medical oncologist having to look after hundreds and hundreds of patients a day and treat every single cancer site. You can also see it in an individual sitting in a high income country that may only be seeing 10, 15 in their clinic. But because of the structural constraints and the economic constraints, every patient's having to make life or death decisions about whether they can afford to be treated or not. And so we kind of in the commission, I think, point out the fact that we've been really remiss in the way we think about cancer care and the policies around cancer care in understanding what it means to create a workforce that is engaged and is happy and is not subject to this kind of dreadful, degrading, often dehumanizing conditions for which we see many medical oncologists and surgeons and clinical oncologists around the world having to put up with. And that includes everything from the conditions all the way through to salaries. We forget in many countries the salaries for the healthcare workers are truly, truly dreadful. And we wonder why we experience such difficulty in recruitment and retention and in the general pathway. So I think, as you said, it's an important area, and it's one that I think needs a lot more work.
Yeah, thanks, Richard. I think what really I heard from that is that this commission is really about the experience of cancer rather than the outcome, which I think has been a focus of so much of our cancer ecosystem. But this is truly about the patient experience as well as the clinician experience. So I just wanted to pull on that thread of education a little bit more, which you do discuss, education of our healthcare professionals and our support staff. Do you think that the commission, based on your evaluation, are we currently providing the right kind of education to our healthcare professionals to provide the experience that patients need in their cancer care? Or are there different skills and supports that we need to give along the educational pathway to make sure our healthcare professionals are equipped to deal with the psychosocial needs of persons dealing with cancer?
Mm. So I think we're in an interesting situation when it comes to education. I think for a lot of oncology, and I talk here about all the disciplines, radiation, systemic therapies, surgical, the technical developments have progressed. not equally, because in lots of systems we still have serious issues around technical competence. But there's no doubt that technical expertise has improved because of the nature and the evolution of the tools we now use. But what's been sacrificed in order to do more and more education around the genomics and the targeting and the high-end technical pieces, what's been sacrificed has been this ability to understand the wider sort of social and family history of our patients. What's been sacrificed is the inability to sort of critically appraise the information and the evidence that's constantly flowing into our respective disciplines. And obviously, this is something where CSO is extremely important in focusing. And we actually have a particular section on CSO with the Commission to talk about what are the elements of current education that are missing around the world. And these are generalities we're making here, where these are sort of basic 101 educational aspects of bringing individuals up who are going to be trained in the principles of oncology. Because at the moment, to be trained in the principles of oncology means to be trained in the technical aspects. As I said, the genomics, etc., not in the wider humanistic aspects. How do you integrate palliative care? How do you have discussions with patients at the end of life so that they are empowered to make the right choice for them and not feel they constantly have to go through more and more treatment? And I think this is really important because I think the sense we're getting talking to people is that we're losing that humanistic training within the principles of oncology, and we're not inculcating enough a rigorous and critical appraisal of the evidence that's now increasingly washing over all our young sort of healthcare professionals coming through. And without having that ability to separate the wheat from the chaff when it comes to evidence, and to be able to say, well, this is really useful because it's based on really good data from well-designed trials, and this is not useful or suspect, we are going to be constantly, I think, going to be caught in this sort of technification of cancer patients, where all that matters is to continue treat. And we don't talk about a good death. We don't talk about a good end of life because we see death as a complete and total failure because all it is about cure and keeping people alive.
No, I think that's a really excellent point. But I want to ask maybe a slightly different question next. Some listeners on the podcast might think that a more human-centered approach to cancer would be fantastic, but do we really want to spend our limited healthcare dollars pursuing this if it means we can't continue to invest in identifying the new breakthrough treatments? And, I think this idea of breakthrough treatments is something that is perpetuated in our research environments, it's perpetuated in the media, it's perpetuated in our clinics, and it's really become the thing that we always strive for. So what's your response? Is this really a choice that our cancer systems need to make, or can we have it both ways?
We have struggled generally with this because we assume innovation, compassionate, human-centered care are zero-sum games. To get one, the other must lose. When the answer is that technologies, and this is, I think, really important. It doesn't matter if it's a robot, a multi-cancer detection test, a new systemic therapy. They are nothing more than tools. They're inanimate tools. They have no agency. They have no intrinsic value. Their value rests in how they are used entirely. And so when you say to people, look, this is not a zero-sum game. What we're trying to do here is create an ecosystem, a human-centered ecosystem, where those tools can be appropriately deployed. And I would strongly argue to get the best out of any of the technologies we use to treat our cancer patients, we need systems that are absolutely integrated and human-centered. Because without that, you simply will not get the best out, and we know that, and so it's not for me. This isn't a zero-sum game, and it's blindingly obvious, I think, to all of us, and I think CSO as well, that the tools cannot overcome systemic failures. So if the system is failing, no amount of new cancer drugs, no amount of new surgical robots, no amount of new radiotherapy techniques can overcome those failures, and that's something that I think the public and patients living with cancer probably often don't get right. And I understand why, because the constant media hype is if only you had this drug, if only you had this new multi-cancer early detection test, then the world would be better because you'd be diagnosed early, you'd have been saved, you would have been, and that kernel of truth is disconnected from the reality, the systemic reality, which yes, it will, but if the only if the system works. And so this is I think when we were thinking about the commission and what this human crisis is, we kind of realized a lot of this was about systemic failure. There's no failure. I mean, I would argue the innovation pipeline is stunning. It's stunning. And it's not just coming from the West now. We're seeing this absolute explosion of technical innovation coming out of China now, which is being added into the general global ecosystem. The innovation is not the problem. It is the fact of the systems which don't exist, which mean the technical innovations never make it to patients, systems which allow misuse, systems which allow overuse, and systems which allow variation. And all of those things are to the detriment of the human-centered care.
So, Richard, let's talk a little bit more about systems. So, we're constantly evaluating our healthcare system, and one of the ways we do this is by creating what we call quality metrics. And they provide us feedback to help us identify areas where we're doing well, but equally areas where we need to make change. How do our quality metrics currently fail in establishing a human-centered cancer care system? And what shifts would you like to see in these quality metrics for us to have, measurable targets to improve outcomes for patients?
That's it was an interesting debate. I think first of all to say within the commission, we debated this at length. I mean, within the health systems world, we have something called Donabendian conceptual model, which talks about structures, processes, and outcome indicators. And that is a very operational and, in a sense, academic structure. And there are a few countries around the world that have outstanding, what we consider to be service level quality indicator programs and quality improvement programs. Number one is probably the National Cancer Audits of England and Wales. Number two, places like Denmark. But we're talking a handful or two handfuls of countries that have what I consider to be, including Canada, those basic service indicators. The patient experience one is a different matter, though. That's fine. And by the way, we need more of those in other countries because there's no doubt that from a purely service and systemic, clinical systemic point of view, we have a serious quality problem around the world. And part of dealing with this problem is, first of all, to illuminate where it is. So I think there's that technical aspect is absolutely fine, but it does not look into then the issues of human-centered care in terms of compassion, access to good psychosocial, access to good palliative care, and of course, in some of the more forward-thinking places around the world, we're talking more about patient-reported outcome measures now. We're talking more about, you'll see countries now, we have patient surveys, but it's an interesting problem because the sense we got when we were doing this commission is they're still quite instrumental. They're still quite metricized and bound into the biomedical model. I mean, even PROMs and PREMs, patient-reported experience measures and patient-reported outcome measures, have come out of a regulatory discourse in clinical trials, in other words, clinical research. So I think there's actually room here to start thinking about how one might go about eliciting what good human-centered cancer care ought to look and feel like, and how we might not even measure it, perhaps describe it. Measuring can often mean instrumentalization. Maybe this is a descriptive element here. Maybe we're talking about ethnographic studies in countries, etc. But I think this is where we talk about this in the commission, where the social sciences and the world of cancer haven't talked to each other enough. And I think there's a lot more interesting work than the social scientists, the anthropologists, the ethnographers can bring in to the world of cancer by studying exactly how we might follow and describe really human-centered, person-centered cancer care and compassionate care.
Yeah, thanks, Richard.
Work to be done.
Certainly a lot of work to be done. Let's hear a little bit more about some of the solutions that the commission proposes. So, you've identified these massive gaps in where we'd like to be and where we currently are. And to someone sitting on the outside, they seem almost insurmountable at times. But the commission does outline some potential solutions and ways forward that I think are really important for our listeners to hear about. So, can you tell us a little bit more about that?
Yeah, absolutely. I think first and foremost, there's a need for, I think like most problem sets, there is a need to kind of accept that we do have this crisis ongoing, and to accept that the crisis is nuanced and complex and multidimensional and it affects us all, and that whilst we can congratulate ourselves for a job well done on discovery science, on new technologies, whilst those of us that sit in countries with improving outcomes can give ourselves a pat on the back that we're doing really well, or we're trying to do our very best, that we have serious problems. And so there's part of the solution, strangely enough, is just to say to people, when you're talking about owning this problem, it has to be owned by all of us. It needs to be owned by the clinical community, by the patient advocacy community. We also say as well, it needs to be owned by industry as well. It is in industry's interest to improve all the things we talk about. It is in the commercial interest to do that. And also from a sort of political perspective, from a national perspective. And owning that is important, because owning it means also that you become part of the solution set rather than expecting other people to bring those solutions to you. You're kind of developing. And in a sense, and this is going to sound very controversial, the crisis we've now been seeing with the US withdrawal from global funding, the crisis we're seeing, conflicts in Gaza and Sudan and Ukraine, these crises are waking people up to agency. They're removing people away from dependency. They're making people start looking at their own political systems and their own citizens, and asking what resources do we need to mobilize to improve things? How do we politically ensure the health and the care of our citizens? This is a good thing, because I think there's been too much aid dependency, and there's been too many governments that simply didn't prioritize cancer and health care. So those solutions, I think that's number one, is a big piece within the commission itself. We then go into kind of what you would consider probably more meso level solutions, which is, how do we change education systems and curricula for healthcare professionals? Integrating CSO principles, integrating principles of our view, and I think this was a really nice piece of work that Daria Trapani led, integrating much more holistic training into our principles of oncology. And that means some fundamental aspects of teaching social and family histories, deeper understanding of how to deliver mental health within cancer care, psychosocial, and really importantly, making palliative care an integral part of all our care. Because at the end of the day, it's not, we're going to be dealing with many, often in most cases, most patients who are going to die. And this is, a good death is as important. So this is something we think within the solutions bit is really important. We also then sort of talk about the importance for engagement in dealing with this problem, systemic problems, in terms of fragmentation, in terms of care, in terms of financial toxicity. And again, we talk about people driving their own agendas to improve operational sciences. We talk about the R&D system. And again, moving back up again, particularly with the R&D, I think we push a lot of the solutions onto research funding organizations around the world in terms of rebalancing the R&D agenda. And that includes federal and philanthropic, who right now, in our view, within this commission, are failing to deliver human-centered research and development. And I think that, the solutions come out and flow out for each of those. And of course, we refer back to a lot of previous commissions, for example, that have articulated some fantastic solutions in those commissions, because I think people often forget that lots and lots of people have been writing about different areas over the last decade. And I think what we've tried to do within this commission is to refer back to those other ones and say, go back and read this, this, and this, and this. And I think the workforce one is probably one of the more unique aspects, for example, is how we need to build, a much more human-centered workforce. And that is a technical aspect, that's a philosophical approach, and that's also a financial piece of work. So, this is a solution, but I think it's first and foremost this kind of ownership within the commission, within the community at large, because I think if it's not owned by the community at large, we'll be still, you and I will be talking about this in another 5 or 10 years' time, and we'll be seeing very little progress.
So, Richard, I think we're getting close to time, but I wanted to ask you one last question. You've given us some great solutions, but I want to hear about some solutions that maybe can be adopted today. So what can oncologists, patient advocates, or others listening to this podcast, what can they do right now in their own healthcare systems and countries to help move the needle and refocus on human-centered cancer care?
Right now, I think they can advocate to those individuals in power and with money what needs to change within their ecosystem, both from a research perspective, an education perspective, and a care perspective. So those three dimensions, and I would strongly argue that we're responsible for all three of those dimensions, and we have to do all three of those dimensions together. And so within each country, it's no good just arguing for one of those aspects. You have to bring all three together. And the more that can be done, the better things will be. And I think the engagement piece here really is for people to shine light on what the specificities of the human crisis are in their context, because this is a general overview. And as I said right at the beginning of the podcast, these general overviews need to be specified for individual ecosystems. So taking this framework and asking, what's the human crisis in cancer in Brazil? What's the human crisis of cancer in Botswana? And articulating those gives them then a roadmap for where the realistic, immediate and midterm interventions can actually be. But they have to be in those three dimensions. And it also enables individuals from outside who are friends and colleagues and research partners from around the world to understand better, I think, how we can help and interdigitate. Because I think at the moment we often talk across purposes, and I think that's really important. And I finally think, right at the highest level, we need to have a much, much stronger, hard-nosed advocacy and a realistic advocacy for cancer care reform, generally speaking. I think there's too much platitudes go on. There's too much high-level discussion in nice fancy hotels in Geneva and in Washington and New York, and it's completely disconnected from the lived reality in other countries. And I think people need to start advocating from the lived reality into those higher levels, because at the moment, those voices, in my view, are not being heard.
Well, thank you so much, Richard. It really is a fantastic commission, and I wanted to thank yourself, but also all of the other commissioners for the really fantastic and important work that has been done on the human crisis in cancer care. I'd like to close with a final thought-provoking quote that I pulled from the manuscript, which I think is really pertinent, and that is, the rehumanization of care is not a luxury. It's a clinical, moral, and systemic imperative. So with that, thank you everyone who tuned in today. Please remember to subscribe to the Common Sense Oncology YouTube channel and visit commonsenseoncology.org to sign up for free as a CSO member. Thanks again, and see you next time.